ladies and gentlemen, we also have another video with Dr. Apostolov. And by the way, many or some of his surgeries are also combined surgeries, glaucoma and cataract. And besides that, he also works with comics, with 1.6, 1.8 sizes. And we will have a look at one of those surgeries. So let's see.
All eyes are the same. There are quite some eyes with shallow anterior chambers, and if the depth of the anterior chamber is under the 2 millimeters, then it may be a bit tricky to to introduce the phaco tip and to maneuver the phaco tip into the eye. So in those eyes, I like to use the comics tip, the 1.6, 1.8 millimeter. Decades ago, Bob Osher introduced the concept of slow motion phaco emulsification, and there are certainly eyes where one would offer a bit of speed for more control. And small eyes, short eyes, one can never be too careful with them. So the comics tip gives more control. Everything goes a bit slower in a controlled manner, and that makes the operation safer. So here the capsular axis has been made, the hydrodissection, the hydrodelineation has been made, and the phaco tip is being introduced. I like to put the foremost part of the phaco tip into incision and then start the irrigation, not after the tip is into the eye, because that avoids air bubbles and startling the patient. Here I'm doing a trick I learned recently from my friend Neto Rosotelli from Brazil. That's the so-called nucleus spin. So the nucleus is being rotated a number of times in both directions. That loosens the cortex and makes the cortex removal easier, and if done properly, even unnecessary, as the whole cortex may be gone after the phaco emulsification. Here the first job is being made, and making sure that it has propagated on both sides. Then after the nucleus is split, I do the spin one more time in hope that the edges of the nucleus will loosen the cortex. And then I proceed with further chopping and removal the nucleus. Well, you can see that the comic tips, despite the smaller size of the incision, gives a good anterior chamber stability. No post-occlusion surges, and it allows efficiently to remove the nucleus. Well,
one question. Can you tell us something about the grade of the nucleus, how hard it is?
Well, it's a grade 3, this one. It's not the hardest kind of nuclei, but it's hard enough to be chopped nicely. Well, as you can see, I'm turning the phaco tip all the time in order to engage the nuclear fragment from the best possible angle. And well, it will be soon all gone.
And also here, I repeat, the values are also on the maximum. I believe you have 650 vacuum, and the flow is something between 35 and 37. Is that correct?
Correct. Those are the parameters.
So you do not differ between the size is 2.2 and 1.8 microcomics. You you use basically the same settings. Is that correct?
Yes, yes, I'm using the same settings because I don't see any difference in anterior chamber stability.
Okay, good, great.
Here, the last piece of the nucleus, and then the epi-nucleus. Well, despite my efforts with the nucleus spin technique, the cortex has not been removed completely. But, well, here I'm using also something I do the last time. I'm using the reflux to flush the epi-nucleus out of the capsular bag. And after that, well, it does not take long to get it out of the eye. When busy with the last pieces of nucleus or epi-nucleus, I like to hold the chopper in a flat position right under the phaco tip in order to protect the posterior capsule may a surge occur. And here I proceed with the irrigation aspiration. I like also to move both instruments, not just hold the irrigation in one place, but point it well between the capsules to hold the capsular bag open, and sometimes to direct it differently. I don't need to switch hands, but in this case I did, because it's a left eye and I can not turn the aspiration tip anyway with the opening facing the capsule. So I have to move it to the temporal side, and then it's not a problem. Here I'm getting some last pieces of cortex removed, and then I start polishing the posterior capsule, which I do in every case, and I'm pleased with the clarity of the posterior capsule. Here the incision is being enlarged to 2.2 millimeters in order to be able to introduce the injector of the lens.
Now, regarding the injector, you told me, probably when I'm not misunderstanding it, you're trying to find an injector 1.8 millimeter to avoid this incision. Is that correct?
Well, it would be nice, to keep the incision size to 1.6. It may be possible with wound-assisted injection, which I'm a bit hesitant to do because I don't like the lens to touch the outside of the eye anyway. And it would be, maybe it would be possible with another injector with the thinner walls of the cartridge.
Okay, good.
So here the lens go into the capsular bag. I push also the trailing haptic into the bag. And next, the OVD is being removed from, all over the anterior chamber, and of course from behind the IOL.
Valentin, I have a very stupid question to you, but maybe
They say
some of
there are
our
no stupid questions.
sales force would understand it. What happens if you do not remove the visco properly? Does that have horrible consequences for the patient, or what happens?
Well, the consequences are that the pressure rises in the hours after the surgery, in the afternoon, in the evening, and that's not good for the health of the optic nerve, and also the patient may experience pain. Of course, that's for any lens, and for toric lenses, it's even more important, because if you don't remove meticulously all the OVD, then the lens, the chance is higher that the toric lens will rotate.
Very good. Thank you very much.
So here I'm both instruments go behind the lens, and both irrigation and aspiration are being used to remove, like here with the irrigation, to remove the OVD from behind the lens, and then I turn the lens and I repeat the same maneuver, because there is a tendency that a small amount of OVD stays at the 6 o'clock position. And well, next the incision is being hydrated and some cefuroxime injected and checked if the eye pressure is well between normal and 1+, in order to guarantee the eye is being sealed. Well, all 3 incisions, the 2 side ports and the main port, are being hydrated and checked if the pressure is at the desired level.
Okay, I think that was once again a very good and interesting example, especially by turning the nucleus to avoid to avoid more cortex, I think. And that's you learned that from your Brazilian colleague, what I understood, and that's new for me as well.
Well, I have to, I'm still in the beginning. He's much better at getting all the cortex away than I am at the moment, but well, that will improve with time.
Okay. One last statement from your side is, now you're working for more than 1 year with Oertli. In your OLVG group, you have 2 sites, one in Amsterdam and one in Amsterdam, but they are quite far away from each other. And what is the experience you have in terms of quality, support, and the performance of the Oertli? Can you tell us something?
Well, we're very pleased with both machines we have. They work good for chopping. They work also very efficiently for divide and conquer, for sculpting the nucleus. We haven't had any issue with the machines which could not be resolved after restarting. And whenever well, there is something, then we get fast enough support from your company, which we appreciate. And of course, we are looking forward to the new software.
By the way, yes, we have a very close relationship with Dr. Valentin Apostolov, not only regarding Oertli, also regarding scientific issues, where he gives us a great input of the near future, of the far future, what can be changed, what will be changed. And that helps us to be very close to the daily business. That means, in other words, yes, Oertli is out of the field, and we feel what is going on based on such inputs, which are, by the way, also very nice documented. Valentin, thank you very much for this interview, and see you soon.
You're welcome, Alessandro.